LVAD, Education for Nurses in the Skilled Nursing Setting. At the end of this module presentation, there will be a quiz. You must complete the quiz with an 80% or higher grade to complete the entire module. The purpose of the LVAD policy and training is to provide a guideline for nursing staff to assist the resident in using their LVAD device in the treatment of left-sided heart failure. LVAD stands for Left Ventricular Assist Device. It is an implanted pump that takes over the function of the left ventricle. The control unit is worn outside the body and is connected via the driveline that goes through a small opening in the skin. A physician's order is required for the LVAD. Prior to hospital discharge, speed, power, and flow settings are set. These settings should not be changed by staff in the long-term care setting. Nursing shall monitor the resident for heart complications as well as driveline infections. Dressing change frequency is ordered by the physician. In power chart, type ventricular in the order search box and ventricular assist device will come up. Put the order frequency in and enter the details in the special instructions. All residents receiving LVAD therapy should be on anticoagulants. Labs are faxed to the responsible VAD coordinator as well as the covering physician. Observe the resident at regular intervals. Every 2 to 3 hours is suggested, checking for alarms, complications, or adverse effects. Pulse ox checks may be indicated depending on the resident's condition. Vital signs should be done Q shift. The patient may be on a fluid restriction. They should be on a daily wait. Make sure the battery charging station is plugged into the wall, and they should have at least 2 spare batteries in the charging station. A green light indicates a full charge. Facilities maintenance should be performing an electrical check on the unit prior to use. The LVAD may be connected to the power module, which is plugged into the wall, or to allow more mobility, the patient may wear the batteries in a holster. You'll find that most patients will wear the holster during the day, and at night they'll be plugged into their wall charger. When the device is plugged into the module, several numbers on the system monitor indicate pump flow, pump speed, pulse index, and power. Always change out the white power cables first, and then the black when switching power sources. This is the way that the patient is trained in the hospital. To switch out the cables, first push the connectors of the white cables together and turn counterclockwise to disconnect. To reconnect, align the half moons on the connectors, push them together, and turn clockwise until they're flush. Do not force them. Repeat the same steps with the black cables. Never disconnect both sets of cables at the same time. This essentially leaves the patient without a power source. The system controller itself provides a power for a limited amount of time, but never rely on it. Tell the patient the device will sound an alarm when changing between power sources, and it is very loud. To do a proper assessment of your LVAD patient, make sure you monitor their blood pressure and mean arterial pressure. You'll have to use a Doppler because due to the pump and the sound that it makes, you will not be able to effectively obtain a blood pressure using your stethoscope. The MAP goal for these patients is anywhere from 60 to 90. An elevated MAP indicates a low blood flow and perfusion to the heart. If the MAP is too high, the patient may require antihypertensive drugs such as metoprolol, hydralazine, or isosorbide dinitrate. These drugs need to be adjusted until the goal MAP is reached. Usually the patients come to us with a well-adjusted MAP, but we should always be checking. Always check with the provider before holding any medications due to a low MAP. To To check your patient's blood pressure using a Doppler, first obtain the Doppler device and gel. Apply the gel to the inside of the patient's arm where you would check the brachial pulse. Place the blood pressure cuff on the patient's arm and then turn the Doppler on. Hold the Doppler probe gently over the brachial pulse until a good signal is obtained. The best signal will be obtained with the probe at an angle between 45 and 60 degrees to the artery. The artery may not be parallel to the skin. An adjustment of the probe may be required to obtain a good signal. Once you have it in place and hear the whooshing sound of the blood, it helps to have a second pair of hands to hold it there while you inflate the cuff. Inflate the cuff until you no longer can hear the whooshing sound. Slowly release the cuff until you begin to hear the sound again. This is the map. Then clean the gel off of the patient's arm using a gauze. Only nurses will be checking the blood pressure using a Doppler. You should also frequently assess the patient's driveline site. Driveline site should always be covered with a dressing, though some patients, especially if they are confused, may remove the dressing themselves. We should be watching for that every time we work with our patient. Make sure the dressing is intact and occlusive, and change it per the doctor's orders. Inspect the driveline for any tears, bends, or kinks, and make sure it is connected and locked into the system controller. Report any signs of infection, such as increased white blood cells or positive cultures, redness, drainage, or pain at the exit site. Driveline infections are relatively common. Stabilization or securement device is intact to the driveline lead to protect movement at the exit site. When changing the driveline dressing, assess the driveline site, or more frequently, you can assess the driveline site if you're concerned about dislodgement. Except under special circumstances, the driveline dressings must be changed daily or every other day depending on the provider's order and how long the patient has had the LVAD. To change the driveline dressing, close the door and limit traffic in the area. Air currents can stir up dust and bacteria. Stop fans, heaters, and air conditioners or cover the units. Gather your supplies. Both the resident and caregiver should wear a mask during dressing change. Then perform hand hygiene and apply clean gloves. Gently remove the old dressing and discard it into a trash can. Perform hand hygiene and apply clean gloves. Cleanse the driveline site with ChloraPrep, wiping using concentric circles for 30 seconds. Allow that to dry and place a dressing over the driveline exit site. Dressing should have an occlusive seal all around the edges of the site before peeling back the top layer to reveal the final dressing. The driveline is secured by a drain patch. Drivelines need to have gauze placed around the lead prior to the patch placement so that the lead is protected from the hard plastic strap to prevent a tear. It's important that the nursing team monitors for any alarms. Call the LVAD team for any alarms for troubleshooting. Verify that the running symbol on the controller is illuminated green. This means the pump is running and operating as intended. Do not attempt to troubleshoot alarms without the assistance of the LVAD coordinator. Do not change the controller. The metal connections to the batteries in the clips and in the pockets of the battery charger should be wiped off weekly with an alcohol swab. Do not submerge the driveline or any other system component in water or liquid. Confirm that the resident has had at least 4 fully charged batteries ready for use. A spare emergency bag should be available at bedside with a backup controller and batteries. Patients with LVADs are typically prescribed several medications, including anticoagulants, antiplatelet agents, antihypertensives, antiarrhythmics, fluids, and electrolytes. We've already talked about the anticoagulants are prescribed for LVAD patients. For example, heparin, warfarin, and aspirin. help prevent pump thrombosis. However, these drugs do increase hemorrhage risk. For antihypertensives, vasodilators such as hydralazine and isosorbide dinitrate, beta blockers such as metoprolol and carvedilol, and ACE inhibitors such as lisinopril. Always monitor heart rate and blood pressure when giving these medications. Most patients with heart failure are restricted to 2 liters of fluid per day, but you may find that some residents with LVADs who depend on adequate volume and pressure to maintain flow need fluids to be pushed to achieve the best filling pressures. Also check their electrolytes such as potassium, magnesium, sodium, and calcium to keep them within normal ranges. This will help prevent arrhythmias. They will need to have regular BMPs, CBCs, and the PT-INRs as ordered. Keep in mind the signs of compromised fluid status. Common indications of decreased fluid volume include a decreased pump flow and pulse index, and an increased hemoglobin and hematocrit. Common indications of fluid overload include weight gain, edema, and shortness of breath. During emergencies, ensure that all the LVAD connections are secure. Make sure the driveline is connected to the controller and the controller is connected to power. If the device is alarming, immediately call the LVAD coordinator. The phone number is at all the nurses' stations. Your patient may be pulseless. Always try to get a Doppler blood pressure if possible. Listen for the pump sounds by placing your stethoscope on the patient's chest and listen for a whooshing sound. You may do CPR on these patients if they are not a DNR. If you're sending the resident to the ER, please make sure to send all their equipment with them. Document the resident assessment utilizing LVAD therapy and any adverse effects. Include settings, map, dressing changes, site assessment, and the resident's activity tolerance. LVAD complications include blood clots. Keep in mind symptoms of stroke include facial drooping, visual changes, slurred speech, and one-sided weakness, as well as severe headache. You should call 911 immediately if you recognize signs of a stroke. Another complication is hemolysis. This is the breakdown of red blood cells, which is most likely caused by a clot in the pump. You may see the power number elevated and sustained, usually over 9. They may have coke-colored urine, elevated LDH, as well as signs and symptoms of heart failure. Also be on the lookout for signs and symptoms of hemorrhage. Lifelong anticoagulant use puts patient at risk for hemorrhage, especially stroke or GI bleeding. You will see frank red to black tarry stools with GI bleeds, a significant drop in hematocrit, decreased O2 sat, pallor, dizziness. You may have to have the anticoagulant therapy adjusted, and the resident may require a transfusion. Also be on the lookout for arrhythmias, such as ventricular tachycardia and AFib, which are common in LVAD patients. After LVAD placement, arrhythmias are medically managed with antiarrhythmic agents such as amiodarone and digoxin. A new onset arrhythmia must be reported to the doctor, regardless if they are symptomatic. When filling out the resident profile, please add risk for cardiovascular complications, risk for infection, and need for psychosocial support and risk of depression. Be sure to document the patient's code status, as well as whether or not they would like to be sent to the hospital if there is a change of condition. Do not forget to place the patient on enhanced barrier precautions and put in the resident isolation order for EBP. In the comment section of that order, write in LVAD as the reason for enhanced barrier. It is the nurse's responsibility to seek out information to care for a patient with an LVAD. It is never okay to leave a task undone because we do not know how to do it. Ask for help when you don't know how to do something. Many patients are aware of how to care for their LVAD and can lend a hand with their own LVAD at times. If opportunity to learn from the LVAD expert arises, do not skip this valuable training. It is highly recommended that you watch the videos on YouTube for the specific LVAD your patient has. Obtain a copy of the manual to keep at the nurse's station. Thank you for attending this training. Now proceed to the quiz.